Good morning, everyone. Today, I am going to discuss about necrotizing ulcerative gingivitis. It is a severe inflammatory disease of the gingiva which is caused by the bacteria. It occurs in an impaired host with risk factors. It is also known as Vincent's infection or trench mouth disease. And the characteristic clinical signs include necrosis and sloughing of the gingival tissue, and it will be accompanied by systemic symptoms as well. Necrotizing ulcerative gingivitis can cause tissue destruction, which involves the periodontal attachment apparatus, especially in patients with long-standing disease or immunosuppression. Classification. There can be an acute stage, subacute stage, and recurrent stage. In subacute stage, there will be diminution in the severity without the treatment, and there will be history of repeated exacerbations and remissions, whereas in recurrent stage occurs in previously treated cases, and it can involve single teeth, group of teeth, or maybe widespread throughout the mouth. So what are the oral signs? The patients will give a history of sudden onset of symptoms, sometimes occurring after an episode of debilitating disease or an acute respiratory tract infection. And there will be a change in living habits of the patient, or there can be a protracted work without adequate rest, poor nutrition, tobacco use, or psychological stress. And there will be a characteristic lesion which will be punched out, crater-like depression at the crest of the interdental papilla, which will extend to the marginal gingiva and rarely to the attached gingiva and oral mucosa. The surface of the gingival crater will be covered by a gray pseudomembranous slough that is demarcated from the surrounding gingival mucosa by a pronounced linear gingival erythema. And in some cases, the lesions are denuded of the surface pseudomembrane, during which the exposing of the gingival margin occurs, which will be red, shiny, and hemorrhagic. The characteristic lesion can progressively destroy the gingiva and underlying periodontal tissue. There will be spontaneous gingival hemorrhage and pronounced bleeding after even the slightest stimulation, and these are the characteristic clinical signs of the disease. There will be fetid odor and increased salivation, which is also a common characteristic of necrotizing ulcerative gingivitis. So we cannot see any pocket formation in necrotizing ulcerative gingivitis. What will be the reason? So necrotizing ulcerative gingivitis can be superimposed on either gingivitis or periodontitis with periodontal pockets, but it does not lead to pocket formation because the necrotic changes involves the gingiva and entire junctional epithelium. And for the pocket formation, we know that we need a healthy epithelium and a junctional epithelium for formation. So that is why in the necrotizing ulcerative diseases, we cannot see any periodontal pocket. So what are the oral symptoms? There will be an excessive amount of pasty saliva. The lesion will be extremely sensitive to touch, and there will be constant radiating gnawing pain to the patient, and the pain will be intensified by eating spicy or hot food and while chewing also, and there will be metallic foul taste. And there can be extraoral and systemic signs and symptoms. Patients will be ambulatory with minimum systemic symptoms. In mild to moderate stages, there can be local lymphadenopathy, slight elevation of the temperature. Whereas in severe cases, we can see high fever, increased pulse rate, leukocytosis, loss of appetite, and general lassitude. And the systemic reactions can be insomnia, constipation, GIT disorders, headache, and mental depression. And in very severe cases, there can be gangrenous stomatitis and also noma. So what are the clinical cause of the disease? It can vary between individuals. If untreated, necrotizing ulcerative gingivitis can lead to necrotizing ulcerative periodontitis with progressive destruction of the periodontium and gingival recession. And there will be also increase in the severity of systemic complication if left untreated. So what are the stages in the progression of necrotizing ulcerative gingivitis? Pinborg has described some stages. Initially, there will be erosion only of the tip of the interdental papilla. Later, it can extend to the marginal gingiva and that can lead to complete loss of the papilla. Later, it can affect the attached gingiva and can lead to the exposure of the bone also. And Horning and Cohen have given 7 stages for the necrotizing ulcerative gingivitis. And stage 1 involves a necrosis of the tip of the interdental papilla only. And stage 2, there will be entire papilla necrosis. In stage 3, the necrosis will extend to the gingival margin. And in stage 4, it will extend to the attached gingiva. And in stage 5, necrosis extend to the buccal or labial mucosa. Whereas in stage 6, it extends to the alveolar bone. In stage 7, there will be necrosis perforating the skin of the cheek, which is known as noma. Coming to the histopathology. Microscopically, non-specific acute necrotizing inflammation of the gingival margin can be seen, and it involves both epithelium and the underlying connective tissue. The surface epithelium will be destroyed and will be replaced by meshwork of fibrin, necrotic epithelial cells, PMNs, and various types of microorganisms, that is pseudomembrane. And at the immediate border of the necrotic pseudomembrane, we can see the epithelium, which will be edematous, and the individual cells exhibit varying degree of hydrophic degeneration. And in addition, there is an infiltration of PMN in the intracellular space. Connective tissue is markedly hyperemic with numerous engorged capillaries and dense infiltration of neutrophils. And it appears clinically as linear gingival erythema beneath the surface of the pseudomembrane. And there will be numerous plasma cells in the periphery of the infiltrate. So what are the etiology of the necrotizing ulcerative gingivitis? The primary role is bacteria. Primary causative factor is Fusobacillus and spirochetes, which is known as fusospirochetal complex. And other than, there will be involvement of Treponema microdentium, intermediate spirochetes, Vibrios, Fusiform bacilli, filamentous organism, Borrelia species also. And other than bacteria, host response plays an important role. And in such patients, the host response will be impaired and all the predisposing factors will be associated with immunosuppression. And we can also see defect in polymorphonuclear neutrophil chemotaxis and phagocytosis. And immunodeficiency can be related to nutritional deficiency, fatigue caused by chronic sleep deprivation, oral health habits, psychological factors, or systemic disease, HIV infection, etc. Local predisposing factors can be either pre-existing gingivitis, smoking, deep periodontal pockets and pericoronal flaps, areas of gingiva traumatized by opposing tooth and malocclusion. And systemic predisposing factors can be either nutritional deficiency, fatigue, oral health habits, psychological factors, systemic diseases like diabetes, and in case of debilitating diseases like cancer, syphilis, GIT disorder, blood dyscrasiasis, and HIV. So Liscard et al. Described 4 zones of acute necrotizing ulcerative gingivitis. Zone 1 is bacterial zone. In this, there will be superficial layer which consisting of varied bacteria, including few spirochetes. And zone 2 is neutrophil-rich zone. There will be numerous leukocytes with bacteria and spirochetes between them. In zone 3 is necrotic zone. There will be disintegrated tissue cells, fibrillar materials, and remnants of collagen fibers and numerous spirochetes. And zone 4 is the zone of spirochetal infiltration. It consists of well-preserved tissue infiltrated with intermediate and large spirochetes without any other organisms. So epidemiology and prevalence. It occurs in an epidemic pattern. It can occur in all age and highest chances between 20 to 30 years of age. And in India, 54% can be seen in children below 10 years of age. So coming to the diagnosis. First of all, clinical find is the main thing. Gingival pain, ulceration, and bleeding will be there. And we should check the bacterial smear and we should take the biopsy if possible. And treatment. During the first visit, we should evaluate the patient and we should take the complete medical history and special attention will be given to the recent illness. We should inquire about the living condition of the patient, dietary background, cigarette smoking, type of employment, hours of rest, risk factors for HIV, and psychosocial parameters like stress or any depression. And followed by, we should examine the patient. We should examine the general appearance. We should check vital signs, presence of any skin lesions, halitosis, palpation for any enlarged lymph nodes, especially submaxillary and submental lymph nodes. It should be followed by oral cavity or intraoral examination. We should check for the characteristic lesion of the neck and its distribution and the possible involvement of the oropharyngeal region. And we should check the oral hygiene status of the patient and should check for any presence of pericoronal flap, periodontal pocket, any local factors like poor restorations or calculations. And we should initiate the therapy after that. The goal of the initial therapy is to reduce the microbial load and to remove necrotic tissues to the degree that repair and regeneration of the normal tissue barriers are established. And treatment during the initial visit is confined to acutely involved areas only. Acutely involved areas are isolated with cotton rolls and dried, and we should apply topical anesthetic. And after 2 to 3 minutes, the areas are gently swabbed with a moist cotton pellet, and we will remove the pseudomembrane and non-attached surface debris. And each cotton pellet is used in a small area. And after the area is cleansed with warm water, and if superficial calculus, if any, is removed. And in this case, ultrasound scalers are very useful. And we should prescribe the antibiotics. Patient with moderate or severe necrotizing ulcerative gingivitis with local lymphadenopathy and other systemic signs and symptoms are prescribed amoxicillin 500 milligram orally, 6 hourly for 10 days. And if it is sensitive to amoxicillin, erythromycin is prescribed 500 mg every 6 hours and metronidazole 500 mg twice daily for 7 days. Surgical procedures. Extractions and periodontal surgeries are postponed until the patient has been symptom-free for 4 weeks, and emergency surgery is carried under systemic antibiotics. Patient will be instructed to avoid alcohol, tobacco, to take adequate rest, pursue usual activities, but to avoid excessive physical exertion, avoid exposure to sun, and he will be asked to rinse with full glass of equal mixture of 3% hydrogen peroxide and warm water every 2 hours or twice daily with 0.12% chlorhexidine solution, and nutritional supplements will be given. We should be instructed to confine toothbrushing to remove the surface debris with bland dentifrice and ultra-soft toothbrush. And overzealous brushing and dental flossing and the interdental brushes are painful. The analgesic will be prescribed if there is pain, and report back in 1 to 2 days is advised. And during the second visit, which will be 1 to 2 days after the first visit, we will be evaluate for the amelioration of signs and symptoms. Condition will be usually improved and pain will be diminished. Gingival margin will be erythematous but without pseudomembrane. Scaling is performed if necessary and if sensitivity permits. Shrinkage of the gingiva will expose previously covered calculus, which will be gently removed, and same instructions are given. And during the third visit, it will be scheduled after the 5 days and evaluated for any resolution of symptoms. Comprehensive plan for the management of the patient's periodontal condition will be done. Patient should be symptom-free. Some erythema may still present in the involved areas, and gingiva may pain tactile stimulation. Proper plaque control procedure will be given, and hydrogen peroxide mouthwash is discontinued and will be advised to continue chlorhexidine mouthwash for 2 to 3 weeks. And he will be advised to take proper nutrition, plenty of fluids, smoking cessation, scaling and root planing if necessary, treating chronic gingivitis, periodontal pockets, pericoronal flap, and local irritation. And he will be reevaluated after 1 month. Thank you.